Obviously we've given you guys talks on sort of the basics of POCUS during one of the prior academic half days. And then for most of you who went through the sim lab and cycle 2, you got at least the basics of lung ultrasound. And so now we sort of just wanted to break down one of the most important aspects of point-of-care ultrasound, which is assessing LV function at the bedside. And really we're going to go through, the main cardiac views again and discuss how we evaluate the function in each of those views. And then after, about a quick review of that, we'll have a series of clips where you guys, audience participation is strongly encouraged. So we'll have a poll where you guys will be assessing the function for each of the clips. And we have a series of about 15 clips. So if we can get some good audience turnout, that would be excellent. But obviously, if anything doesn't make sense or is confusing as we sort of walk through the slides, please interrupt me, ask questions in the chat, okay? And with that, we'll get started. So really just the basics of left ventricular function evaluation. So, obviously point-of-care ultrasound is different from formal transthoracic cardiography, right? So we're not measuring LV function in terms of, ejection fraction of 83%, right? So we're really just qualitatively categorizing LV function as either hyperdynamic, normal, reduced, or severely reduced. And these are really the only real qualitative ways that we categorize it at the bedside. Typically, if we wanted to get further determinations of ejection fraction, diastolic dysfunction, if we're analyzing regional wall motion abnormalities or assessing structural abnormalities, this in general requires additional training. You can do a lot of these things at the bedside, but that'll not be part of the purpose of this talk today. So really just reviewing the basics, starting with your classic parasternal long axis view, and then at the bottom left hand of the screen we sort of have how you should be holding the probe with the body probe. With the cardiac settings, you want the dot pointing to the right shoulder, and that correlates with that little P up here at the top of your screen. And again, this parasternal long axis view is looking mainly at the LV here with the right ventricle outflow tract up top. And then you have your aortic valve and aortic outflow tract here. And then you have your left atrium and mitral valve here. And then if we had increased the depth slightly, you would see this circular structure down here as the descending aorta. And that's helpful again for determining whether if you see, let's say, fluid above it or black anechoic spot above it, that would be more indicative of a pericardial effusion. Whereas if it was below it or to the side of it, that would be more indicative of a pleural effusion. And then this little dot here, which you sometimes will see is the coronary sinus. But really looking at this view for LV function, we look at 3 different things. So, did it pause? Hold on one second. It should keep playing, but there we go. So we're looking at the thickening of the walls with contraction. So all these walls thickening with each contraction. Is the cavity size, so the volume or the area of anechoic blood in the left ventricle, shrinking appropriately with contraction? And then is there adequate movement of the mitral valve? And really we're paying particular attention to the anterior leaflet because it's closest to the probe. So we're looking at this one. And ideally you want to touch towards the septal wall in function, for function to at least be normal or hyperdynamic. Yeah, sorry. And then, so there's an extra view that we can use with the parasternal long axis view, and that's called the E-point septal separation. So this is focusing very specifically on the anterior, or the movement of the anterior mitral valve towards the septal wall. So once you have an adequate parasternal long axis view, what you can do is you can put that at the tip of the anterior leaflet near the center of your screen, and then use your M mode, which again evaluates motion of a specific area over time. And you're looking, basically what that's doing is it looking at the minimum distance between the anterior leaflet tip and the interventricular septum. And based on the distance that you're able to calculate, you can insinuate whether you might have normal LV function. So typically if it's less than 7 millimeter distance between the anterior leaflet and the septal wall. If it's 7 to 10 millimeters, it's sort of indeterminate. And usually if it's greater than 10 millimeters, it likely doesn't, the anterior leaflet likely doesn't move beyond the halfway point during contraction. That suggests reduced LV function. This is just an example of a parasternal long axis view. And really what we're looking at is this anterior leaflet here. And you want to see with contraction how close it gets. So at the closest point to the septum wall, that's where you're going to be measuring. And so if you imagine just putting the MO, that's a dotted line here in the same area, and you're seeing this movement of the anterior leaflet here, this is sort of calculating it at the closest distance. And so this would be suggestive of a reduced LV function because it's sort of greater than 10 millimeters or greater than 1 centimeter. Any questions about that? So your parasternal long axis view is going to be one of your most helpful views for assessing LV function, but I personally like to use the parasternal short axis. And the reason that I like this view is because it gives us a nice circular view of the left ventricle. So we're really seeing all sides of the left ventricle, and we can really analyze the movement of each aspect of the left ventricular wall. And again, if you're evaluating LV function, you want to evaluate it at the papillary muscles, which are sort of these boxing gloves at 5 and 7 o'clock. And again, just to remind you guys, to get the parasternal short axis view from your parasternal long axis view, you're in the same location, but you rotate your probe 90 degrees so that the dot is now pointing to the left shoulder instead of the right. And so the structures again are the right ventricle up top. And then this is the left ventricle here in the center. And really what you want to use this view to see is all aspects, all sides of the left ventricle moving concentrically and equally? And is there appropriate shrinking of the cavity size with each contraction? You can also pay attention to the thickness of the LV diameter, right? Because that might be concerning if it's too thick for something like a hypertrophic cardiomyopathy. But really for LV function purposes, you were really sort of just looking at what's called the fractional shortening method. So this is just an example of the LV at end diastole and the LV during contraction, right? So they sort of created a nice circle shape here at its widest point, and this is at the end of contraction. And really for LV function to be normal, you want this diameter of this circle to decrease by at least a third. And the reason why we say that is if you sort of remember going back to your geometry, like area of a circle is pi r squared, right? So let's say if the radius was 6, right, initially, so that's 36 pi, right? If we want the diameter to shrink by a third, so from 6 to 4, so 4 squared times pi is 25 pi. So really, 16 pi. So really that would be more than a 50% decrease in the area, right? So that would denote at least normal ejection fraction. So sometimes, when you have this view, you may not appreciate that the walls are moving in like significantly, and that's okay. You really just need the diameter to decrease by at least a third or more. This is just an example I just had to include. So if we're looking for something like cardiomyopathies, your parasternal short axis view is going to be one of the main views to look at. And again, this is sort of just pointing to the fact that the thickness of the diameter or the thickness of the wall is more than what you would expect. And really what we want to do it is at the end diastole, you want to look at the diameter, and normal thickness should be 6 to 12 millimeters. So if it's more than that, that could suggest something like a hypertrophic cardiomyopathy. And then you also can look at the end diastolic LV diameter as well, and you want it to be at least 40 to 60 millimeters. Of course, we have a couple other views, right, when looking at the heart. So this is just an example of assessing LV function with the apical 4-chamber view. So again, now we're sort of going mid-clavicular, below the nipple, with the dot still pointing to the left shoulder. And this is really going to be your main view to look at all 4 chambers with an emphasis on the apex, right? So we're getting a very good look at the left ventricular apex. And then I will admit this is not the best 4-chamber view, but you can appreciate this is the aortic valve here. The right ventricle would be over here. This is the mitral valve coming in, so left atrium would probably be around here. And the reason why I included this clip is you can see, if you notice, the apex is sort of ballooning out compared to the rest of the left ventricle. And so this would be an example of someone who might have like a Takotsubo cardiomyopathy or a stress-induced cardiomyopathy. So this is, if you're worried about something like that, the parasternal, the apical 4-chamber view would be the most sensitive one to look for that. All right. And then, of course, a lot of times, especially realistically with our patients who may have, increased body habitus or difficult anatomy for whatever reason, sometimes we can't get a good apical 4-chamber view. So we can't look at all 4 chambers of the heart. So really the only option in that case is to go subcostal or subxiphoid. And again, with this view, you're really sort of digging the probe under the sternum and using the tip of the sternum and using sort of the liver as like a echogenic or acoustic window. And this now your dot is pointed to 3 o'clock, right? So it's going to be directed to the left. And again, this is another 4-chamber view where the right heart structures are closest to the probe. So the first thing that you'll see is the right ventricle, the right atrium's over here. This is the left ventricle, and then this is the left atrium here. This is actually almost a 5-chamber view because you're seeing a little bit of the aortic valve. And really, this just adds additional information. If for whatever reason you can't get a good look at all 4 chambers from the apical 4 view. I would say if we're assessing LV function and we think that the function might be reduced, this would be the main view that we would then use to look at the IVC. So we would rotate the probe 90 degrees and look at the IVC diameter. And if the IVC is plump or non-collapsible, it might be consistent with something like a fluid overload decompensated heart failure type state. Especially in patients who are in shock, it helps with our differential as well. So that's really just a quick run through of left ventricle function assessment. So now we're sort of going to move on to just a series of sample clips where we'll sort of not necessarily quiz you, but get you more comfortable with assessing function on your own. So if we can. So for each of these clips, there's about 15 clips. The answer choices are going to be the same for each one. You're going to have A being hyperdynamic, B normal, C is going to be reduced, and D is going to be severely reduced. And I think what we'll do is we'll just do a bunch of sample clips just to see, and then we'll discuss them as we go along. Any questions before we get to the clips about any of the cardiac views or what else we're maybe looking for?
Yeah, I wanted to ask on the previous one, did the previous one have like a small effusion or?
This one?
Yeah.
Let's see. Hold on 1 second. It's not I may have to just it's hard to say. Normally, if you would see fluid, like we should see it all the way around, like around here, maybe like a very slight sliver. Here, it's I wouldn't call it like an effusion just based on this view. I'd want to see it more circumferential. So I would say, if anything, it's very small. This might just either be a piece of the liver or even like some pericardial fat or structure, but maybe like very tiny sliver. If you saw a pericardial effusion, you'd see it probably right up here.
I see. Okay.
Any other questions? All right. So, Jackie, are we able to do the polls?
Sure, I'll launch it now. Hopefully everyone can see that. And everyone answer, feel free to guess if you don't know, just so we can get an idea. So we have about 10 people.
So we can get to like at least more than 50% response, then we'll move on. Yeah.
Right, we have 42 people. Just take a guess, guys.
Just take a guess. I mean, I'm not like, going to grade you. It's not going to go in your
anonymous.
evals or anything, right? It's really just for your own practice.
Okay, I think we have 70%, so we can go with that now.
And can we see the results?
So let me
Oh, there we go. Okay. So we have about 53% looks like reduced, and then 33% severely reduced. All right, and then we have some hyperdynamic and normal. So yeah, I think the majority of you guys understood that this looked like that maybe things weren't moving too well, right? So, and really what we want to look at is, are the walls moving in significantly with each contraction, and is the cavity size shrinking? So I would say there's some movement, as we get closer to the mitral valve, right? You can see some movement here and here, but the cavity itself really doesn't change much, right? It stays pretty much the same. So this is actually a patient who had a severely reduced EF. So as we get more practice with it, you guys will get more of the hang of, you can compare it to someone who might just have a mildly reduced LV function. Any questions about this? And this patient actually does have a little bit of a pericardial effusion here, you can see. Okay, but good, yeah, all right. And then, sorry, Jackie, can we keep track of like the actual numbers of people who answer? Is that possible?
Yeah, we'll take snapshots of all of the results, so we have the percentage and amount of people.
Thank you so much. Thank you.
Of course.
All right, so let's go for this one.
So hopefully everyone can see. And feel free to guess as well. Okay, so we'd like more than half. A few more. Okay, so we have 75%, so I'll
Excellent.
show it now.
All right, so about 50% said reduced, and then there was the rest of the remainder was tossed up between hyperdynamic, normal, or severely reduced. So let's take a look at this one. So really, this is your classic parasternal. Actually, I should be asking you guys. All right, so with each clip, if someone could just in the chat name the view. I mean, this one's a little bit labeled, so ignore. But this is a classic parasternal long axis view. All right, so we're getting a very good view of the left ventricle here, and from this view, right, there's 3 ways to assess the LV function. So we look at the contraction of the walls, right? So how much they're moving with each contraction, and then you want to look at the cavity size. Is it shrinking sufficiently? Ideally more than 50%. And then you also want to look at the anterior leaflet of the mitral valve, right? So it should at least cross the midway point. And in theory, we could use the E-point septal separation to really determine how close it gets to that mitral valve. So I think in this view, for me, there's some movement of the walls, and then there's a little bit of decrease in the cavity size with contraction, but it's not sufficient really to denote a normal ejection fraction. The other tell maybe is that if we look at the anterior leaflet, it maybe goes to about the halfway point, I would say halfway towards the septal wall. It doesn't, touch the septal wall or get within real close distance to the septal wall. So those are all signs to me that the function is reduced. And I would say compared to the other clip, the contraction and the thickening of the walls is a little bit more so than the first one. So this was actually just a patient who had mild or moderately reduced LV function. So the answer here was C. So the majority of you guys got it, so that's excellent. Any questions about this? Gonna go to this one. All right.
Okay, so far half have maybe answered. Just give it another couple of seconds.
All right, you guys are good. So 90% said hyperdynamic, 10% said normal, and then no one said reduce or severely reduce. And then in the chat, what do we guys think of this view? Okay, good. Does everyone agree with the view? So yeah, this is yeah. I will say I don't know if I did this one. I can't remember who did this view. I don't know, so I don't want to take credit or bash anyone. But yeah, so this is a parasternal short axis view, and you can tell because the left ventricle is nice and circular, donut shaped, right? This is actually the right ventricle. It's probably we're not seeing the papillary muscles, right? And because of right ventricle not releasing the cavity size, this to me is probably closer to the left ventricle apex. So I agree, it's not an ideal parasternal short axis view. But from what we can see here, right, if we look at the cavity, right, the anechoic fluid-filled left ventricle cavity, with contraction, it completely obliterates, completely goes away, right? And so this certainly, the diameter of the cavity size certainly shrinks more than a third, right? It probably goes all the way to 0. So this view would be would denote hyperdynamic LV function, which most of you guys agreed. So that's excellent. All right. What about this one?
Okay, so we're almost halfway.
All right, so we have 66% with normal, 28% with reduced, and then a couple for hyperdynamic and severely reduced. All right, so yeah, this one, I think is tricky. I think, it's always going to be hard to determine the LV function for apical 4 chamber, right? Because we're sort of just looking at it lengthwise, right? But you really want to pay attention to how the walls are moving in with contraction, right? So whether there's a significant enough movement with contraction or not. And so there is movement, I would agree. But for me, the cavity size doesn't really significantly shrink with contraction, right? There should be at least still a decrease in diameter by around a third or more. And we're not really seeing that. So this is actually a patient who ended up having some mildly reduced LV function. Any questions about that one? And then, yep, I see it. Sorry, I forgot to quiz you guys, but you guys accurately described this as an apical 4 chamber view. Excellent. All right. And then, just to keep you guys focused, what's the structure here on this side? All right, good. What about here? All right. Can't trick you guys. Good. And then what's the valve here? Excellent. Yeah. All right. Good. You guys are good with the anatomy. All right. So we'll go on to the next clip.
I think pretty unanimous voting on this one.
All right. Yes. Almost everyone said severely reduced. Yep. And what is the view in this one?
So when we're saying
Excellent.
parasternal short.
Yeah, excellent. So again, when you see a nice circular left ventricle, it really is only parasternal short in terms of like the point of care ultrasound views, right? And like I said, for LV function to likely be at least normal, you want the diameter to decrease by a third. And I would say in this view, it's barely moving at all, right? And really there's no change in thickness with contraction. So I would agree that this view is pretty standard for severely reduced. And also, it's possible that maybe the left ventricle could even be dilated. I mean, it's taking up the entirety of the view. We're not even able to see the right ventricle. So this could be someone who might have a dilated cardiomyopathy, but I probably want to see a few other views too before I would say that for sure.
So almost 50%, just a few more. I think we've been good for having like 70% answer.
All right, so it looks like the majority say hyperdynamic, and then there's some for normal, and maybe 1 or 2 for reduced. So first off, what view is this?
So Juan is saying parasternal long in the chat.
So if we look, right, what is this structure up here? I agree, I would say this is probably a suboptimal view, But yeah, so this is actually subcostal, and the way we know that, so anytime we see, if we can make out, so I would say subcostal views tend to be the hardest to get sometimes, depending on patient's body habitus and other factors, if there's bowel gas and things like that. But if we can make out four structures, right? So this is a ventricle, this is a ventricle, and then these are the atria here. Then it's either apical 4 or subcostal, and based on the tilt, right? And what is this up here? Yeah, so this is the liver up here, right? So if we're using the liver as an acoustic window, it has to be that we're, you know, sort of below the thorax looking up towards the heart. So this is going to be a subcostal view. And really, you know, if we're only looking at LV function, we sort of need to distract or sort of remove ourselves from looking at all of these other structures and really just focusing on the left ventricle here. And when it comes into view, you want to be able to see, okay, how much is the cavity size going in and out? And it actually does almost obliterate with contraction. So this is a patient who ended up having a hyperdynamic Lv function. And you can see the movement of the walls is pretty significant as well. Question on that? All right. All right. So the majority of you guys said normal, and then there's some for hyperdynamic, and then maybe some for reduce. And then, so what view is this, guys? All right, excellent. And then what is the structure up here? All right, good, good. I see a lot of RV, RVOT, yeah, our right ventricle outflow tract, right? And then what is this structure here? Yeah, exactly, mitral valve. And then, so, you know, with this view again, right, so excellent, this is parasternal long, right? We've identified all the key structures. This is the left ventricle here. This is the movement of the walls. I know it says, I don't know if the patient actually was on 15 mics of leaf of head or not, you know, whether the patient was in shock, who knows. I don't know the context of a lot of these clips, but the things that I'm looking at most in this view again is sort of the anterior leaflet of the mitral valve and the movement of the walls, right? And if you can see here, right, the walls. So if I leave my sort of my pointer here, with contraction, the wall actually moves quite a bit. And then if we look at like the diameter of the ventricle, the cavity size, it actually does decrease significantly with contraction. And then the anterior leaflet doesn't fully touch the septal wall, but it definitely gets pretty close. And so this is a patient who ended up having normal EF. So yeah, you guys nailed it. It's excellent. This, by the way, you know, I think it could be mistaken for fluid. My guess would be that this is probably pericardial fat. It doesn't look completely anechoic like black blood here. So I probably wouldn't call this a pericardial effusion. I would have wanted to see it maybe more like around the descending aorta, which we don't see. All right, so we're saying 93% hyperdynamic, excellent, and then there's maybe a couple for normal and reduced. So very good. And then what is the view here? So I see Arpon saying apical 4, Sherrell's apical 4. Excellent. Yeah. So this is I would say, you know, it's not the best apical 4. You know, this is, what's the structure here? Exactly, yeah. So this is the left ventricle. So you sort of have to imagine that the right ventricle, right atrium are here, and then this is the left atrium, and then this is the mitral valve. And then these are the, if you look here, right, this is, it's a little bit grainy, but these are the walls here and here. And essentially they're like basically coming into contact with each other with contractions. So the cavity is getting completely obliterated with contraction. So this is, I agree, this is an example of a patient with hyperdynamic function. All right, so what about this one? All right, so it looks like 79% said severely reduced, and there were some for reduced, and then a couple for normal. So again, what view is this, guys? All right, so crutis is parasternal long, and so I guess what are some of the structures here, right? So what is this? Yep, sure. Parasternal long. What is the structure here? Aortic valve, excellent. And what's this here? Mitral valve, right? And then this whole structure here, LV, good. And then really, I mean, what do we think of the movement, right? So again, I look at the walls thickening with contraction, the cavity size shrinking, right? The cavity seems to be pretty much the same throughout the entirety of the clip, right? I mean, there's some movement as we get closer to the aortic outflow tract. And then if we look at the anterior leaflet of the mitral valve, right, it barely moves up. It definitely doesn't cross midline, right? So it's even less than midline. So yeah, I would agree that this patient has severely reduced LV function. Excellent. All right, so we have 79% with hyperdynamic, and then around 21% saying normal. Nothing for reducer or severely reduced. So, okay, so a couple of things. Okay, good. All right, Juan's already ready. So apical 4, yeah, I agree. This is probably apical 4. I would say it's like the tilt is a little bit strange, right? So, you know, you could mistake it for a sub-xiphoid view, but we don't really see liver up top. So it makes me think that this is apical 4. And then before we get to the LV, is there anything like abnormal that you guys think is going on with this clip? Like, what do we think about some of the other structures of the heart? Yeah, so Juan and Arpan are saying RV dilated. Yeah, I definitely would agree, right? So if we look, sorry, go back, yeah. If we look, right, our right ventricle, which we'll probably talk about in like a future talk, should be at least 2/3 or smaller than the size, 2/3 the size or smaller of the left ventricle. In this clip, the RV actually almost looks bigger to me, right? And it looks like something that maybe is acute because the wall isn't really thickened like it is with the left ventricle. So the RV is dilated, and maybe the apex of the RV is moving a little bit more so than the rest of the right ventricle. So this is someone who could have some signs of right ventricular pressure overload, whether it's from a pulmonary embolism or some other etiology. I'm not really sure, but if we're just paying attention to the left ventricle, right, we sort of are looking at the movement of the left ventricle, right? And in this view, again, the cavity almost gets completely obliterated, right? The walls are moving in fully, and the anechoic or black area is completely going away. So I think for LV function, it's probably hyperdynamic, but I assume this patient had the POCUS for other reasons. All right. All right, so we have about 55% saying reduce, and then some saying severely reduce, and then a few saying normal. So first off, again, what view is this? All right, excellent. Yeah, so parasternal short, and then just to make sure we get our anatomy, what is up here? RV, excellent. And then we're seeing something here, maybe a little bit on this side as well. What is this? Yeah, so these are the papillary muscles. So this is a good area to actually evaluate the LV function. Right, what is this that's coming into view for part of the clip that's sort of making it harder to get our LV function assessment? Yeah, so there's some lung sliding going about halfway into the clip, so it obscures part of the left ventricle, but we can at least see the septal wall pretty clearly throughout, and then we know we're at the level of the papillary muscles. And so really what we're trying to do is see how far the diameter lessens with contraction. And while there's some movement, you know, I would say it doesn't go more than a third. So I would say it's definitely not normal, and I think it's moving a little bit well enough that I wouldn't jump to saying it was severely reduced, right, just based on this singular view. So this is someone who probably had mild to moderately reduced LV function. All right. And again, this is actually a very adequate, if it wasn't for the lung view, this would be a nice adequate parasternal short axis view with the left ventricle in the center. RV is like a crescent shaped up top. You can make the depth a little bit less because this is all extra space that distracts from the view. All right, so we have majority saying severely reduced, and then some saying reduce, and then no one says hyperdynamic or normal. Okay, good. And then what is this one? All right, subcostal. Does everyone else agree? So this is a subcostal view, right? Because it's 4 chambers, right? We're seeing 4 different structures here. And then the first thing that comes into view, so the thing that's closest to the probe, is going to be the right heart structures, right? So you have your right ventricle here, which you're kind of seeing. It looks very small, right atrium here. And then, so what is this structure here? Yep. Yeah, so you have your left ventricle here, and then your left atrium is here. And then this is some movement of the mitral valve. And really what we're trying to gauge again is how well the walls are moving in this view. And so as we get closer to the mitral valve, there is some movement, but then when you get closer to probably the LV apex, there's really not much movement, and the cavity size does not shrink appropriately with contraction. So this is someone who has severely reduced EF. And honestly, I think this might be someone who's like pericode. I don't know the context again, but it doesn't look like there's that much flow of blood. Let's see.
So waiting on a few more.
All right, so we have 54% saying normal, and then there's a mix between reduced, severely reduced, and then maybe a couple saying hyperdynamic. So again, this maybe is not the most ideal view, but what are we looking at here? Yeah. parasternal long axis. And so what's up here? Yeah, RVOT, right? And then you have your aortic valve here, your mitral valve, and then you have the interventricular septal wall is probably here. We're not really seeing the other aspects of the left ventricle or even cavity size, really, maybe slightly a little bit of movement here. So really the main thing that I have to go on with this view, if I had to assess LV function, was the anterior leaflet, right? So we need to see how close does it actually get to the septal wall. And if you look, it's sometimes hard to see, but it definitely goes past midline. It actually almost goes up to about here. So it's probably within a few millimeters of the septal wall. So this is probably, so this is someone who did end up having normal LV function. Okay, but I think this would not be an ideal view to make a final assessment. I think we'd have to try and do some other views. Certainly the parasternal short axis view, and maybe even like an apical 4 if able to. And then what is this structure down here? Yeah, excellent. So the descending aorta, and then this is important, right? If we are seeing fluid above it, right, then that would be indicative of pericardial effusion. If we were seeing fluid sort of to the side or below, that would be a pleural effusion, which we're not seeing either in this case. So we have just a couple more clips. All right, so we have 85% with hyperdynamic and then 12% say normal. And then I think maybe 1 or 2 people said reduced. So if we look at it, so what is this view? So this is actually, I will say the societies is throwing, I don't know what this is meant to be. So we have to try and see what structures we can identify, right? So what is this over here? Yeah, so this is actually parasternal long axis, right? And if we take a closer look, this is right. So this is the left ventricle here. You can see the thick walls here. And then this here is what? Yeah, so this is the aorta. So this is the aortic valve. And so if this is the aortic valve, this is the left ventricle, what does that make this structure? Mitral valve, right? And then this would be the RVOT up here. And you can kind of tell we're in the thorax because this is part of some lung that's sliding in. So that's another tell. But I think, this is definitely off axis. The structures are sort of twisted a little bit in a different way than we would normally see in a typical parasternal long axis view. And really with this view, what we're looking at, again, is the movement of the walls with contraction, right? The cavity is getting completely obliterated with contractions disappearing. And then the anterior leaflet, right, is basically touching the septal wall right here. So those are all signs that this is hyperdynamic function. All right.
We just need a few more. We've maybe 50% have done it so far, so feel free to guess, guys.
And these are meant to, all right, good. So we have differential between reduced and severely reduced. So yeah, I mean, this is, this is intentionally tricky, right? Because I think this is sort of the reality of point of care ultrasound, right? Like we can't always get the most ideal views every time, right? And we sort of have to make these global assessments based on the views that we can get. So what is this view here of the heart? Yeah, so this is the subcostal, right? And you can see sort of the right ventricle up here, right atrium, and then you sort of have your left ventricle down here. Then you have a liver here. And so that's how we know we're in the abdomen looking towards the heart. And, I think this question is very tricky. I think whether you said reduced or severely reduced, I think you can argue for either or. This patient ended up having just moderately reduced LV function. And I think, what's tricky about it is just that we're only looking at it in a singular view. I think maybe it would be a little bit easier to decide between the two, depending on what the parasternal short axis looked like, for example. But you can see there is some movement here of the left ventricle wall. The cavity in this singular view, though, doesn't shrink that well. So I agree this is a tricky one. And then the RV is moving almost better than the LV. So that's another sign that there's definitely some left ventricular dysfunction or reduced function. All right, I think we have one more clip, guys. So maybe we can get 100% on this clip. Let's see.
So about half have answered so far. So we do want at least 70%, I guess.
Sure. All right, so we're saying 63% hyperdynamic, and then some for normal, and then some for reduced. And so what view is this, guys, again? Exactly, yes. This is another subcostal view, right? You can see this is the liver up top, and then you have the right heart structures that the ultrasound encounters first, right? So you have the right ventricle up here, the right atrium here. This is the left ventricle here. We're not seeing the apex, but we're seeing basically it's almost a 5-chamber view because this is the aortic valve that's coming into view. And then this is the left atrium here. So from what we can see, I think the axis is probably very off, but you can see that the walls are sort of completely touching one another. And so the cavity is completely obliterating with contraction. I mean, this, depending on the clinical context, could be someone who's in like hypovolemic shock. Maybe there's a hemoglobin of like 1 or 2, 3. They need blood, they need fluid, whatever the case may be. With this singular view, I would classify it as hyperdynamic, just based on how the walls are moving in. So I will say, so we run through, I think, 16 clips. Good job, guys. You actually did. Went through them faster and more efficiently than the residents did when I did it with the residents. Awesome job. We have a few minutes if there's any questions regarding how to get cardiac views or further assess LV function. I'm happy to answer any questions you guys have. Would you say atrial dilatation here? I mean, I think based on this view, I would probably buy atrial dilatation, but I'd want to look at another 4-chamber view. So I'd probably ideally look at an Apical 4 as well, just to verify. I think this one's a little bit off axis, just because we're getting the aortic valve into view as well. But this definitely would look a little biatrial dilation to me. We'll blame Dr. Soloniak for this. Yeah. So will there be a sim lab on this? Well, I can't give everything away. Eventually, I would say we're probably going to do some other organ systems first because everyone likes cardiac. So we usually like to save that last. So if I had to guess, it would be probably late spring or maybe early next academic half year, where there'll be cardiac specific sim case. Yes, Sonny, that's a good pitch for our POCUS selectives. So there's two separate POCUS selectives, right? So there's a hospital selective, which is offered a few times a year, and then there's a critical care elective, which is offered a little bit more frequently. So if you're interested in getting more hands-on training, because obviously we're giving you a lot of lectures on image acquisition and image interpretation, but really we want you guys to be able to get these views on your own at the bedside. And really the only way to do that is hands-on learning, whether that's using our mannequin here in the sim lab, right, which you can access 24 hours a day, or doing one of the POCUS selectives to really get some hands-on experience and direct supervision from myself and some of the other POCUS faculty members. So there's always spots open up, and we have some wiggle room if there's an elective block that you really want to do POCUS, and for whatever reason the currently listed slots don't work out for you. You can email Jose and myself, and we can maybe try and sneak you and fit you in somewhere.
Perfect. If there's no more questions or comments, we can leave it there. But thank you so much again, Dr. Rothman.
Of course, thank you. I'm going to stop sharing.